Okay, everyone, we're going to go ahead and get started today. So, thank you for joining us on this Wednesday. The title of this webinar is Menstruation Matters, Health Management, and Support. And we are here in honor of Women's Health Month, Women's History Month, which is March, to talk about menstruation. Again, as we've said, it's open to anyone who menstruates, anyone who doesn't menstruate, but maybe knows someone that does. I bet you do. So we're going to go ahead and get started today and introduce our speakers. So joining us today, we have from H&H, Dr. Maggie D. Tetrokalavashli, who is the chairwoman at the Department of Obstetrics and Gynecology at NYC Health and Hospital, South Brooklyn Health. Dr. T, thank you so much for joining us today. And we also have Melissa Britton, who is an Investigations and Compliance Officer at CEI, Citywide Equity and Inclusion, with DCAS, the Department of Citywide Administration Services. And I am going to help moderate the conversation. My name is Estrella, and I am the Special Projects Coordinator with WorkWell NYC. Next slide. I'll go ahead and tell you a little bit about WorkWell. So we are the city's worksite wellness team, and we have our programming broken up into 5 different bucket areas. We have the Move More bucket that focuses on promoting physical activity. We have Eat Well that focuses on healthy eating. Take Action highlights primary care and prevention. And then our Be Well bucket is focusing on mental well-being and resilience. And we also have our Project Build, which stands for Building Understanding, Inclusion, Learning, and Diversity, which is our health equity initiative. And it's also a partner in this webinar. So to give us some structure for today's talk, we're going to talk about the menstruation biology and basics with Dr. T, as well as menstrual conditions. And then we will move into some information about reasonable accommodations with Melissa. And then we will have a short Q&A. So with that being said, we'll go into our first section, and I'll go ahead and turn things over to Dr. T.
Thank you very much. Good afternoon, everybody. And first of all, thank you for inviting me to be the guest speaker today. It's truly an honor to be able to have this opportunity to share the expertise. I don't have any financial disclosures. The only disclosure I have that after 30 years of being OBGYN, I did not become an artist. So I use the Google pictures for the presentation. So we'll talk about the menstrual cycle today. Knowledge about menstruation is crucial for promoting overall health and well-being, for understanding our bodies, and of course, for managing our cycles and making informed decisions regarding our reproductive health. So I will start with a little glimpse into the history. On this slide, you see Artemis, who was the daughter of Zeus and sister of Apollo, also known as Diana the Hunter. So she was strongly associated with menstruation and anything that's concerning marriage or childbirth. For example, on the wedding night, girls dedicated all their childhood toys to Artemis at her shrine as a parting to adolescence. So what does the menstruation mean? Menstruation originates from the word mene, right? Latin menses, which means month, and Greek mene, which means moon. And it was considered a cosmic event relating and connecting one to the lunar cycles and the tides. The menstruation from ancient texts, it looks like it was happening around age 14 in girls. And today we know that average age of menstruation, for example, in the United States is 12 or 13 years old. And menstrual blood was treated ambiguously. So on one side, women viewed menstruation as a time of cleansing. And for example, the physician, the Hippocrates, when he saw the women recovered from bloating and aches after menstruation was over, he started to practice bleeding sick people as one of the methods to cure them. On the other hand, the philosopher Aristotle viewed women as unfinished males and viewed menstrual blood as a lesser form of semen. And there is no evidence that menstrual blood was used as a remedy for men. And even in some cultures, the menstrual blood was considered impure for men to touch. It's great to acknowledge that over many years and over generation after generation, especially with education in schools, women are more comfortable to have conversations around the topic of the menstruation. There is more openness, both in practice and in communications. So let's move to the biologic part of the presentation. We all know what the menstruation is. It's discharging of blood and other materials from the uterus through the vagina in intervals of about 1 lunar month. And it starts from puberty until menopause, except when we're pregnant. So each month, the endometrial lining is shed and rebuilt in anticipation of pregnancy. The menstrual cycle is defined as the first day of menstruation of one cycle to the first day of menstruation of another cycle. And the average length of that cycle is 28 days. So average age of menstruation, as I mentioned, when it starts is age 13, and the average age of menopause is 50 years old. But when we talk about the uterus, right, and we talk about the cycle, the fascinating question is, how does the cycle repeats itself? How does it start? And why is it so precise? We all know the power of communication, and we can view the menstrual cycle as the communication between different parts of the body. So you can think about hypothalamus and hypophysis, the structures in the brain, as a CEO and COO, or pilot and co-pilot, and they communicate with each other by sending the neurotransmitters. So hypothalamus makes gonadotropin releasing hormone that travels to hypophysis, and hypophysis makes two hormones. One is follicular stimulating hormone. I think the name explains itself, right? It stimulates the follicles. I will use the name follicle and egg interchangeably throughout the presentation. So it recruits the eggs in the ovaries and stimulates them to grow. And also makes another hormone that's called the luteinizing hormone. This is a second hormone very important for ovulation to happen. Ovulation is when egg is released from its shell in the mid-cycle in order to start its journey and to get fertilized and either become the pregnancy, or if the pregnancy does not happen, then continue continue development and eventually undergo what we call atresia, right, or the programmed death. And these hormones, FSH and LH, they work on the ovaries that produce two main hormones. One is estrogen and another one is progesterone. So ovaries produce, I said, estrogen and progesterone, but interesting, it's also producing androgens, the male hormone. So estrogen is made out of androgen. So if we go back to Aristotle, maybe he was a little bit on the correct path, thinking that we as females make not only female, but also male hormones. Next slide, please. So you can imagine that in that communication pathway, any disruption, any influence can affect it. And our body is affected by energy homeostasis, by what we eat, how much we eat, if we eat too little, if we eat too much, or we are under stress, or our mood changes. So any minor changes, whether it's in the brain or the ovaries or the uterus or anywhere else in the body, can affect the menstrual cycle. Next slide. So let's zoom in a little bit into the ovary. We said that follicular stimulating hormone stimulates eggs to grow. So how many eggs do we have? It is interesting that females prepare to pass the information to next generation, even in the uterus, even before they're born, in the uterus of their mother. So as a fetus, as a female fetus, there are about 6 to 7 million eggs. By the time we grow and age and approach the time of menopause, there are about 1,000 eggs present. So you can think that millions and thousands, both are very large numbers. And if all of them were fertilized, then we would make probably millions of babies or thousands of babies. But that does not happen. Why? Because at the beginning of the cycle, only one dominant egg, dominant follicle is chosen to grow. This is the most receptive. It's a master communicator. It has receptors for the FSH, and it starts to grow and it starts to grow cells around the egg to protect the egg and to nourish an egg until it's ready for the ovulation. So if you see on the left side, this is one of the most important graphs that we learn in medical school because it shows how ovarian cycle is synchronized with hormones and it's synchronized with what's happening in the uterus. So think about the ovary and the egg or the follicle. So egg, for example, as a child, and all the cells that surround the egg as the parents, right? They protect the egg because it's just one tiny cell, and they nourish the egg, and they make sure that egg grows. But at the same time, these are working parents. They make estrogen. So they continue make estrogen until they cannot anymore. So when estrogen reaches this certain threshold, it sends the feedback. It's negative, right? It's not only positive feedback, but negative feedback to the brain saying enough. The egg is mature. It's ready to be released. It's ready to ovulate, and the FSH hormone goes down, and now the LH hormone goes up in order the ovulation to happen. So what happens to that egg when it starts journey? Does it disappear in the body, and is it really free? Not really, because if we look on the right side on the picture of the uterus, it has projections from both sides that are called the fallopian tubes with finger-like projections. And what they do once the egg is released and it's free, they grab the egg and they propel it inside of the channel, inside of the fallopian tube. Now, sperm can survive in the vagina up to 5 days. So if the sperm enters the vagina and then the uterus, it also moves towards the fallopian tube. So the egg and the sperm meet each other in the fallopian tube, they fertilize, and what we call now the embryo, the early embryo, it travels back to the uterus and it attaches to the uterine lining. But the uterus has to be ready, right? It has to be ready for pregnancy. So what does estrogen do? Think about estrogen as a bricks. It starts proliferating the endometrial lining, building it up. But on the second half of the cycle, the progesterone that's made out of those shell cells called corpus luteum, think about it as a mortar. It stabilizes the endometrium and makes sure that it's not shed and it's ready for pregnancy. So if the beautiful pregnancy happens, like in the middle picture, then the HCG, the pregnancy hormone, is produced. And HCG will continue stimulate ovaries to make more estrogen, to make more progesterone, in order the lining not to come out and sustain the pregnancy until placenta takes over the production of those hormones. But if the pregnancy does not happen, the corpus luteum can live only about 14 days. So after 14 days, the production of estrogen and progesterone will stop. That's called the withdrawal of the progesterone, withdrawal of estrogen, so that lining cannot be maintained anymore, and it is shed in the form of the menstrual cycle. So let's look at the uterus. Initially, the menstruation we mentioned, right? Then proliferative phase, ovulation, and secretory phase. So menstruation, the normal length of menstruation is about 3 to 5 days. But anything less than 3 days and anything more than 8 days is considered abnormal. The proliferative phase, the follicular phase, varies. We said that average length of the cycle is 28 days, but we're all different. Some of us are tall, some of us are short. We're all different forms and shapes. So is the menstruation. So the second of the half of the cycle is always 14 days. That's how long the progesterone is made. So if we have 28-day cycle, the ovulation is going to happen right in the middle, day 14. But for example, if we have 38 menstrual cycle, 30 minus 14, ovulation is going to happen on day 16, right? So it's important to know when we try to track the ovulation, and if we think it's only day 14, but our cycle is different, that we might measure the ovulation at the wrong window, wrong timing. So it's important to note. So we said that regular menstruation lasts 3 to 5 days, and the length of the cycle average 28 days. Anything less than 21 days is a short cycle, and more than 35 days is a long cycle. Now, how much do we bleed, right? Sometimes we change a lot of pads and a lot of tampons. So if we change the tampons or pads every hour, that's clearly excessive and abnormal. But normal is to lose only from 10 to 80 cc's of blood. So the menstruation seems that it's much more than 10 to 80 cc's or average 35 cc's. So the answer is that not everything that comes out is actual blood. It's actually that lining of the uterus that could not be sustained and it's shed comes out as well. And sometimes women, they have a misconception or erroneously think that this is early miscarriage, but in reality, this is just the tissue, the endometrial lining that comes together with the blood. So in 5 minutes, I tried to explain the menstrual cycle and what is normal, right? And now let's focus a little bit of what's abnormal. If I speak about each abnormal condition, certainly each abnormal condition is the lecture, 1-hour lecture on its own. So I will try just to give a brief, superficial overview and then focus on certain conditions that are more common and more bothersome. There are a lot of medical terms on this slide. Of course, you don't need to be familiar with them, but the explanation, what do they mean? Certainly, total absence of menstruation is abnormal. Infrequent or too frequent menstruation is abnormal. Very heavy period. Irregular bleeding when we don't know when it's coming, when it's ending, right? Spotting in between periods. Well, pain, we all know that menstruation can be painful, but also it can be a severe pain, disproportionate pain that's called dysmenorrhea, and we need to investigate why it's happening. Mood, the hormones, estrogen, progesterone, they also are linked to other hormones in the body. One of them is serotonin, it's the hormone of happiness. So as the estrogen and progesterone go up and down, so does our mood. So I'm sure a lot of us are familiar with irritability, right, right before the menstrual cycle. So it can be normal, but if it's severe, it can be an indicator or other disorders. And certainly any bleeding after menopause happens. So for example, if we reach the menopausal age and we did not have any bleeding for 6 months or 1 year, and suddenly we start to see the blood, it is considered abnormal and needs further investigation. Around the time of menopause, right, we said average age is 50, 51. So menopause is normal to happen after age 40. And around that time, age 40, age 50, we start having irregular periods because we don't ovulate as much or as often. We can see abnormal, irregular cycles. So sometimes we can say that if that irregularity started, that probably within 4 years, we will transition into the menopause. Right. So let's talk a little bit about certain disorders, right? We said amenorrhea, which is complete absence of menses. And question is it primary, which means menses never happened, or is it secondary? So woman was menstruating and then for some reason she stopped to menstruate. As the adolescent girls approach the age of menstruation, they go through the changes. So start to develop breasts, start to develop hair, pubic hair, axillary hair, and the growth spurt happens and ends with the menstruation. So if, for example, by the age of 14, none of those changes happened and there is no menstruation, it's clearly abnormal. Or by age 16, the sexual characteristics developed, but menstruation did not come, also is considered abnormal. It is normal to irregularities at the beginning once the cycle is still is being established in puberty. But if that irregularity does not go away after 3 to 4 years, we can say that probably the menstruation is not going to regulate on its own and needs further investigation and needs the help. And secondary amenorrhea, right? It's absence of menses in previously menstruating women. If it's more than 6 months or, for example, more than 3 menstrual cycles. And oligomenorrhea is actually menstruation happens, but in reduced frequency, and cycle length is more than 35 days, but is less than 6 months. So this slide shows primary amenorrhea, but also I can say that both primary have many overlapping causes. Number one thing in our mind when somebody complains of no menstruation is always pregnancy. And sometimes we get surprised because the adolescent girl might come and say, I've never had menstruation, there is no way I'm pregnant. But if the ovulation happened on the very first cycle and the pregnancy happened on the very first cycle, then the menstruation might not have happened, but the pregnancy happened. So we always do the pregnancy test. We always check for thyroid because thyroid hormones interact with all the other hormones. We check for prolactin. Prolactin is the hormone that we see during pregnancy or we see in postpartum period. This is the hormone important for breastfeeding and milk production, but it is abnormal to high levels of this hormone outside of the pregnancy. In previous slide, I spoke about recruiting the eggs, right? So each cycle, about 15 to 20 eggs are recruited to grow, but it's a competition and only one dominant follicle grows and the rest of them undergo program death or atresia. But in certain conditions and in central chromosomal abnormalities, for example, such as Turner syndrome, as females, we have XX chromosome, but Turner is XO, only one X chromosome. So those eggs undergo programmed death in much more accelerated phase. So they never might reach the menstruation or they can menstruate and stop prematurely, right? What is premature? Premature is before age 40. As we said, brain is important. So sometimes there are certain conditions in the brain, hormonal changes, or environmental factors, or nutrition that affects the brain function, or certain tumors can affect and can cause abnormal period. Also, the uterus, the shape of the uterus is not always normal. Sometimes it's morphologically abnormal, so it is not responsive to the hormones. And one condition also very interesting, androgen insensitivity syndrome. It's when we have XY, so genetically these are males, but the cells, they do not recognize, they don't respond to androgens, and as a default develop into the females, right? So again, maybe Aristotle was a little bit right when he was talking about androgens and having the female development as a default. So outflow tract obstruction, everything can be okay in the brain, ovaries, uterus, but it might be a septum in the vagina or in perforate hymen where the blood cannot come out. And we'll talk a little bit about polycystic ovaries and Cushing's disease. These are diseases associated with anovulation, and they're very common. And I know that you probably have a lot of questions about PCOS. We're all proud of our athletes, and it's great to exercise, and we have Olympic champions. But sometimes what happens that when athletes spend a lot of energy, right, to be competitive, and sometimes they don't eat or the nutrition is not well balanced, we can see what's called a female athlete triad. Triad is disordered eating, is absence of menstruation because it needs energy, and also the effects on the bone, osteoporosis. So I will not focus on this slide again as a secondary because many causes are very, very similar to primary amenorrhea as a secondary amenorrhea. Now, with polycystic ovaries, a little bit about polycystic ovaries. Again, if we go back to the presentation, we say that one dominant follicle develops under the influence of follicle stimulating hormones. So what happens in polycystic ovaries, right? The name explains itself. Many small follicles grow, but none of them becomes dominant. None of them becomes big enough to ovulate. So these small follicles, they continue to produce androgens and continue to produce estrogen from androgen, but because ovulation does not happen, the progesterone is not produced. So there is a lot of what we call unopposed estrogen and high levels of androgen. And that's how we see how these patients present. They present with irregular bleeding, right? Because there is no ovulation. They present with clinical features of increased androgens, such as hirsutism, acne, or male pattern baldness, or they on the ultrasound, when we look at the ovaries, we do see what we call the string of pearls of very many immature follicles that none of them mature. So tiny follicles, more than 12 follicles in the ovaries. Question is, do we need all three to diagnose? And the answer is no. You need only 2 out of 3 criteria. It's called Rotterdam criteria to diagnose PCOS. So, for example, you can have hirsutism, but regular periods, or you have irregular periods, hirsutism, but when you look at the sono is normal. So, any combination of 2 out of these 3. So, it's interesting that obesity, even though obesity is highly prevalent, is not necessary for diagnosis. You can have lean PCOS patients. Resistance is highly associated in diabetes, but it's not also not part of the diagnosis. So why is PCOS important? It is important not only because of its presentations and not what's bothersome, right, to the patients, the infertility or acne or hirsutism, but it is a lifelong disorder. So there is no treatment that can actually stop the progression of the disease or stop the disease. But it's very important to manage it, very important to manage it because it can lead to diabetes, it can lead to cardiovascular disease, and it can lead to endometrial hyperplasia, endometrial cancer because of unopposed estrogen. So, few words about painful periods. Dysmenorrhea. Again, it is normal sometimes to have pains and aches before period because there is this tissue that's shed. It's a breakdown of endometrial tissue, and any breakdown causes the release of prostaglandins. And prostaglandins, these are uh, uh, they are the ones that cause the pain. But if the pain is so severe that it cannot be managed by, let's say, Advil, by Tylenol, it cannot be managed by birth control pills, the medications, that we certainly need to know, are there any other diseases that are associated with dysmenorrhea? So when we think of what can cause pain, endometriosis, and I'll say a few words about endometriosis. Fibroids, we're all aware about fibroids, the benign growth of the muscle of the uterus, adenomyosis, which is also endometriosis. So these are the cells of the lining of the uterus, but they're actually present inside of the muscle where they're not supposed to be, or they're present somewhere else in the body where they're not supposed to be. Some of the blood that comes out can go back into the belly. It can implant and react to the hormones and act as a menstrual tissue inside of the belly and cause the scar tissue and cause the pain. And also some conditions like Crohn's disease or urinary disorders we always need to exclude. On these slides, again, I will be happy to share the slides at the end of presentations. And because of the timing, I'm not going to go through each of them, but we're all aware that certain things like exercise, sleep, nutrition, relaxation techniques can help to alleviate pain, as well as some medications such as non-steroidal anti-inflammatory medications. Just a couple words about endometriosis, right? It is very prevalent. 1 in 10 women have the endometriosis, and it's very common in reproductive years. And more than 50% of women will have pain, 20% infertility. It's a leading cause of hospitalizations. But the good news is that we can diagnose it. And sometimes, even if we do not diagnose it and diagnose via looking inside of the belly and biopsying those implants, we can also empirically treat it and help women to manage the endometriosis. Fibroids, also very, very common. More than 80% of women have fibroids. They vary in size. So size of the fibroid is never an indication for the treatment. But if they're asymptomatic, there are no symptoms, it's probably not necessary to do anything. Only 1% of the fibroid uterus might undergo the changes and become cancerous. Only 1%, 99% of them are benign. But if patients start to have symptoms, let's say pressure or pain or abnormal bleeding, certainly we can treat fibroids either by removing them or with medications. We always try medications first, certain hormonal IUDs, the medications that stop the bleeding, and even sometimes we can stop the blood supply of arteries to the fibroids. That's called the uterine artery embolization. So we can try all of that before we say that patient is not feeling that she's been helped. So then we talk about removing of the uterus if the childbearing was completed. That's called a hysterectomy. Right. Next slide, please. Okay. Uh, and a little bit about the mood, right? We spoke about the pathologies, but a little bit about the mood, also what happens. Again, because of hormonal fluctuations, we can become irritable, or most of the time we can boost our mood by exercise, by warm bath, meditation, yoga. But sometimes the symptoms are so severe that we cannot manage. And then we talk about premenstrual dysphoric disorder. That's actually part of the psychiatric disorders. Okay. And this PMDD or premenstrual dysphoric disorder, we speak about it when the symptoms are so severe that they cause problems in our social, academic, and personal lives and the work life. So certainly this is the time when it is okay to seek attention not only for OBGYN, but also for behavioral health specialists. And they can give medication sometimes only around the menstrual cycle when the symptoms are present, or if the symptoms continue to present throughout the menstrual cycle, then to help continuously with anxiety, depression, or other severe symptoms. Cycle, the next slide, please. And as we said, the periods last up to about age 51. And then we go to menopause and there are no more periods. So anytime you see the bleeding, even though it can be bleeding because the lining became so thin that it starts to bleed, right? And it is benign. But we always need to make sure that there is no cancer growing inside, no hyperplasia, no cancer. The good news is that endometrial cancer, the presenting symptom is bleeding, and the usually happen on very early stages of the cancer. So there is cure if you seek attention early. We can always talk about other causes, right, of the abnormal bleeding, such as hormone therapy itself, or infection, some medications, and other types of cancer. But again, we have good way to diagnose all these pathologies via biopsy or ultrasound, or looking inside of the uterus, or cleaning the uterus from the lining that's abnormal. And I already mentioned a little bit about postmenopausal bleeding, so I'm not going to take any more time about it. And some risk factors, of course, of endometrial cancer that's common. There's the most common cancer in postmenopausal women. Again, if diagnosed early, it can be treated successfully. Next slide, please. So you Thank you very much for your attention. Right, the take-home message is that we need to know what is happening with our bodies. We need to know what's normal is, what abnormal is, and certainly the symptoms vary by the age, but there are many options to treat. And don't be afraid to discuss. We're always here to help. And if you were a little bit intrigued by the historic part of the presentation, there is actually the Museum of the Menstruation that's part of the virtual museum, part of the Museum of American History. So certainly we can learn a lot of interesting facts about menstruation. Thank you again for your attention, and I'll be happy to answer any questions.
Thank you so much, Dr. T. So we're going to go ahead and move right into Melissa's presentation.
All right. Good afternoon, everyone. I'm happy to be here today. And I would first like to thank our partners at Workwell for inviting me and DCAS to participate in this very important discussion that we're having here today. Again, my name is Melissa Britton. I'm an Investigations and Compliance Officer in Citywide Equity and Inclusion at DCAS. My preferred pronouns are she, her, and hers. For those of you who are not familiar with Citywide Equity and Inclusion, we are the line of service at DCAS that is responsible for ensuring proper and consistent implementation of the city's EO policy and reasonable accommodation procedural guidelines. So we provide guidance on these policies, which impact the city's workforce across over 80 agencies, both mayoral and non-mayoral. We also develop content for the city's mandated EO-related training. So I'm here today to just give you all an understanding of the city's reasonable accommodation process and how it may generally apply to conditions arising from menstruation. However, I'm not here to tell you what reasonable accommodations your agencies must give you. As you will learn, reasonable accommodations are very fact-specific assessments. They consider many variables such as the individual's condition, the essential functions of the job, and the operational needs of the agency. So to start off, I pulled some statistics from the U.S. Bureau of Labor and Statistics that are relevant to today's presentation. So, and the most recent data comes from 2023. So in 2023, women made up 55.4% of the workforce. Women ages 25 to 54 made up approximately 30% of the workforce. And there was a January 2023 article by the University of Virginia Health System, which discussed how menstrual symptoms reduce the workplace productivity of many American women, with 45.2% reporting that their symptoms require them to take days off. And those who needed time off missed an average of 5.8 days of work. The researchers from the study also researched how menstrual symptoms affect women's work productivity, and they analyzed survey responses from over 1,000 women ages 18 and older. And the three most reported menstrual symptoms were cramps, bloating, and fatigue. And when you look at common menstruation-related conditions like endometriosis, PCOS, and PMDD, all of which the doctor just mentioned, they all have these symptoms in common. So one of the key takeaways from this article is that organizations would do well to pay attention to this study and to promote environments where women can feel comfortable in addressing their needs surrounding their menstrual cycle, which brings us to the very important topic that I'm going to discuss today, of reasonable accommodations, which can offer people who menstruate some support and relief in managing their symptoms while also being able to do their jobs. So you all just heard from the doctor the different types of conditions that people may have. So what is there to help people cope with these conditions? So under the New York City's reasonable accommodations policy, accommodations enable individuals who have certain needs under certain qualifying bases to perform the essential functions of their job and to enjoy equal employment opportunities. So an accommodation can be anything from a change to a workplace environment, such as modifying facilities or providing equipment like an adjustable standing desk, a chair, a stool. It can be a change to a rule or practice, such as rules concerning when or where work is performed, when breaks are taken, or how job tasks are to be done, or to an individual's job or operation. So, absent an undue hardship in conducting the agency's business, city agencies must provide reasonable accommodations to all applicants, employees, interns, whether paid or unpaid, as well as to consultants. And so there's really no one size fits all approach. So it's important for an agency's EO office to be reasonable, be flexible, be understanding when engaging in the cooperative dialogue with an employee. They should really be taking an individualized approach to discussing accommodations with an employee and make sure that the communication is timely, because in certain circumstances, the EO office may need to expedite their processing of an accommodation for an employee as necessary. So, under the city's reasonable accommodations policy, there are four covered bases, which I'm going to go over for reasonable accommodations. So those include people with disabilities. It includes people experiencing pregnancy, childbirth, or related medical conditions. It includes people who have religious needs and people who are victims of domestic violence, sex offenses, and stalking as well. And it's important to note that reasonable accommodations are only for the person requesting the accommodation. It's not for somebody else. Also, while someone may express a preferred accommodation, it's really up to the EO officer to determine what is the most reasonable accommodation based on a myriad of factors like the requester's need, the documentation provided, the essential functions the employee does, and any undue hardships that providing the accommodation may pose. So they have to look at all of those factors. Next slide, please. So what is a disability? So I'm going to give you all two definitions today. So the first one is the definition that comes under the Americans with Disabilities Act, which is a person who has a physical or mental impairment that substantially limits one or more of the major life activities, has a record of such an impairment, or has been regarded as having such an impairment. Then the second definition is going to come from the New York City Human Rights Law, which is our local body of law. That's enforced by the New York City Commission on Human Rights. And a disability means any physical, medical, mental, or psychological impairment or a history or record of such impairment. Both temporary or short-term injuries as well as chronic conditions may qualify as disabilities, even if those impairments, when treated, allow the person to perform physical activities without limitation, and or those conditions do not substantially limit the individual's major life activities. So I'm just going to touch on the Pregnant Workers Fairness Act, or PWFA. So this is a federal law that went into effect on June 27, 2023, and it allows employees or applicants with a known limitation related to pregnancy, childbirth, or related medical conditions to be entitled to a reasonable accommodation. And as you'll recall, this is one of the four bases under our city's reasonable accommodations policy as well. So what the PWFA does is it pretty much builds upon the existing protections against pregnancy discrimination under Title VII of the 1964 Civil Rights Act, and access to reasonable accommodations under the ADA, or Americans with Disabilities Act. So the EEOC, or the Equal Employment Opportunity Commission, issued its final rule on April 15, 2024, and the rule provides many examples of reasonable accommodations for employees. So what I'm going to discuss now is just the process for submitting a reasonable accommodation. So the process for submitting a reasonable accommodation is very simple and straightforward. So first of all, an employee should submit a request to their agency's EO office. Employees should not submit requests to their supervisors or managers. After the employee submits the request to the EO office, someone in the EO office will then engage in what's called a cooperative dialogue, which should be done in good faith. And throughout the communication, the employee and the EO office will discuss the employee's accommodation needs, potential accommodations, alternative accommodations, and any difficulties that the accommodation may pose for the agency. And this last point really goes to the undue hardship that the EO office needs to assess before granting any accommodation. And it's really important that the EO office maintains confidentiality throughout this process. It's also the reason why the EO office is the office tasked with handling reasonable accommodations, because they can be an objective entity. They can be impartial and independent when making their determination on an accommodation. So I've talked a little bit about the cooperative dialogue, but just to reiterate, the main purpose of the cooperative dialogue is for the EO office to determine the appropriate reasonable accommodation that will allow the employee to perform their essential function, so long as it does not cause or create an undue hardship on the agency. And so the EO office can ask employees for medical documentation to understand these 4 points up here: the nature, severity, and duration of their condition or impairment, the limitation they have in performing their essential duties, specific accommodations sought, and why they need the accommodation being sought. An exact diagnosis is usually not something that is necessary for the EO office to determine, what accommodation the employee needs. So unless that is necessary, the EO office should not ask for an exact diagnosis or the specific disability. And, just to reiterate, an employee should not ask a supervisor or a manager for an accommodation. Next slide, please. Mhm. So, there should really be no agreements between a supervisor and an employee for an accommodation. Again, employees should submit their request to the EO office. And the reason for this is because it ensures a couple of things. First, it ensures consistent procedures and appropriate documentation of accommodation records for the equitable treatment of all employees. It also ensures that supervisors do not have access to employees' confidential medical information, right? So this is going to eliminate the potential for bias or any discriminatory action on the part of the supervisor towards an employee. The EO office, as part of the cooperative dialogue, can discuss with supervisors and managers the potential impact of an accommodation, as they may need that information to perform, an undue hardship assessment, of course. And again, it's the job of the EO office to consider the employee's needs, so they're going to be looking at all the information and making the decision based on the request. And can we just go back to the last slide too? Yes, and the last point, but not the least point, is that under the city's EO policy, it is prohibited retaliation for an agency to take adverse action against an employee for requesting a reasonable accommodation. So the next slide, these are just some examples of reasonable accommodations for menstruation. I just want you all to keep in mind that this is not an exhaustive list, and there's a universe of possibilities that exist for the types of accommodations that an employee may need. And so just, a few here that you'll see. And then the last slide is just our resources page for folks to take a look at, and you'll get the slide deck. So we have our City of New York Reasonable Accommodation brochure and accommodations at a glance, and a link to the Job Accommodation Network as well, which provides helpful information on workplace accommodations. And just to wrap up, I think one of the key takeaways from this discussion is that if you're having issues performing the essential functions of your job because of any medical conditions related to menstruation, you shouldn't suffer in silence. There are resources available. Talk to your physician about your symptoms and concerns, and you should also definitely talk to your agency's EO office about potential reasonable accommodations if one is needed. So thank you all for your time this afternoon.
Thank you so much, Melissa. That was awesome. A lot of really great information. And again, we are going to be sending out the slide deck with our wrap-up email, so you will have access to all of the information. So we will move on to a short Q&A, and then we'll launch a few quick polls. So there was one question submitted through our Q&A feature. Thank you so much. And it will likely be for Dr. T. It reads, besides lack of a cycle, what are some other symptoms of menopause? And can you speak more about the purpose of HRT, hormone replacement therapy?
Sure. That's a great question. Thank you for the question. Um, uh, yes, so menopause, right? This is it's a life-changing transition for women. And there is a lot of symptoms that can start around the age of menopause, such as hot flashes, or, for example, the vaginal dryness. We're always thinking about developing of osteoporosis, and certainly some chronic conditions such as hypertension, diabetes, right? We're in the age that they can worsen as well or newly develop. So when we talk about hormone replacement therapy, there was one study that's called the WHI Women's Health Initiative Study that changed how we prescribe the hormone therapy. So initially we were giving the hormone replacement therapy to anyone who was complaining of the hot flashes. And then when the study came out, it had a lot of attention, the public and press attention. And it said the hormone replacement therapy might be harmful. It might be increased risk for breast cancer, increased risk for the cardiovascular disease, and the clots, right, thromboembolic disease. So it came out as a general statement. Suddenly, we stopped prescribing it. But when they dissected the study and they viewed at different ages, different groups, what they showed that actually ages 50 to 55, that's when the symptoms are the worst. This hormone replacement therapy might cause a very, very little harm, but actually even be beneficial. Okay, so it can be good for your heart, not bad for your heart. But as the age goes up, after age of 60, certainly we are very careful and we do not prescribe hormone replacement therapy. So please talk to your physician to go over what are the conditions, what are the health risk factors you have. But certainly in a healthy perimenopausal, early postmenopausal woman, there is a role of the hormone replacement therapy. And the question was, how long does the menopause last? Well, I want to be encouraging, but it can actually, the symptoms last sometimes up to 10 years, but most of the time they last from 3 to 5 years. So those 3 to 5 years are symptoms the worst, and the help is available. One more medication that I want to mention, it was just approved by FDA, that's called the Vioza. It is a non-hormonal medication, but it acts on the hypothalamus, the temperature center in the hypothalamus, and regulates how we feel between cold and warm. So it regulates and balances that temperature center and helps with the hot flashes that way. Certainly, there are many non-hormonal medications. They all have their risk profile, some side effects and benefits. And I think it will be great to discuss with your physicians all the options that are available. The take-home message that it is not necessary to suffer. There is help, and we just need to make informative decisions.
Great, thank you so much. So let's go ahead and wrap up. I know there were some other questions in the chat that came in a little bit last minute, and so feel free to email those us to the Workwell inbox, and we can send them off to Dr. T and Melissa as appropriate. But again, we will have the slides sent out at the end. So we're gonna launch a quick poll here.